So we are resuming our lecture, our intrapartum lecture, under primary forces under power. So frequency of the contractions. Contractions are involuntary contractions. We will look at your slide. So I can explain to you the frequency, which means the beginning of one contraction to the beginning of the next. Okay. Just want to make sure that it's going to go to the next slide. Yes. Labor contraction pattern. So duration, so the frequency is the beginning of one contraction to the beginning of the next. Okay? All of this over here, the beginning of one contraction to the beginning of the next contraction. Okay? Duration is the length of the contraction. Okay? Duration. So this is, get my cursor, this is right here is the length of the contraction. Measured from the beginning of increment, up the hill is increment. Okay, up the hill is increment. The beginning of increment to the end of decrement. Down here is decrement. Okay, down here, this is just a labor pattern, a labor contraction pattern. So duration is the length of the contraction. Okay, so right here, the length of the contraction. Okay, right here. The contraction length is a minute. Okay, and it's usually measured in seconds, 60 seconds, 1 minute. Okay. Now, over here is acme. Okay, acme right here. And acme is the peak of the contraction. Okay, is the peak. And usually is 0 to 100. Okay, 100 being the strongest peak, the strongest peak in the contraction. Okay. So increment, acme, down here is decrement, as it's going down is decrement. Okay. And then all of this over here is the duration of the contraction, which is 1 minute. Okay. So again, let's go back and review. Frequency is the beginning of one contraction to the beginning of the next. It's timed in seconds or minutes. Okay. The beginning of one contraction to the beginning of the next. So the beginning of one to the beginning of the next contraction. That's the frequency. Okay. So these contractions are happening every 5 minutes. The beginning of one to the beginning of the next. Okay. Duration is the length of the contraction, measured from the beginning of increment to the end of decrement. And right here, the duration is 1 minute. Okay. Now, all of this right here, all of this line right here, before it starts again, this right here, okay, is called nadir. N-A-D-I-R. And that is the resting phase. This is the period of reoxygenation to start the next contraction. Okay? Because right here, the baby lacks oxygen when there's a contraction. And then, right here in this picture, okay, relief, contraction's over, to the next contraction. Okay, so this here is period of reoxygenation until the next contraction. Okay, we've got other things that are happening as well because the contractions are pushing that baby down and down. So effacement, thinning and shortening of the cervix measured from 0 to 100%. And then we've got dilation, which is the opening of the cervix and is measured 0 to 10 centimeters. Okay. The secondary forces is voluntary use of abdominal muscles, and this is what we're telling mama to push. Okay. Now, we will talk a little bit more about contractions later as well when we go through electronic fetal monitoring and I show you the strip and the top of the electronic fetal monitoring. The top is always going to be the baby's heartbeat, and the bottom is always going to be the contractions, but stay tuned, we'll go through that. So we can't do labor without talking about the psych, okay, the psychological component. So represents a psychological component of childbearing. And those are common emotions during the labor and delivery process. There's excitement, there's fear, there's perceived loss of control, there's anxiety, okay? Of course, all of this, self-esteem has a lot to do with this, the positive relationship with their partner, support system during labor, trust in the medical healthcare providers, trust in that whole medical team. And also remember that psych can also be manifested physiologically as changes in maternal vital signs, increase in blood pressure, pulse, respiratory rate that occurs with fear, okay, that increase in respiratory rate that occurs with fear, excitement, anxiety, all of this also represents, okay, this physiologic psych can also be manifested physiologically in these changes, okay? So psych is very important, okay? This, this psychological change is very, very important. And then, as I promised, electronic fetal monitoring, okay? And when you all get to take turns and get your OB skills day, we talk about electronic fetal monitoring to help you understand it. We are there. We're trying to show you. So it will all enhance all of this learning that we're doing as well. External monitoring, and I'm going to show you the picture so that you could see what we're talking about, has an ultrasound transducer and has a tokodynamometer. Electronic fetal monitoring provides assisted auditory and visual assessment of the fetal heart rate and the uterine contractions. So this is doing both. Okay, auditory and visual assessment of the fetal heart rate and uterine contractions. External monitoring, we've got one, which is the ultrasound, and I'm going to switch to the picture to show you, okay? So, okay, external monitor. So one, okay, usually at the fundus, okay, so this will be the fundus, this is the pelvis, okay, this is the baby down, okay, positioned nicely, see? The fundus, the pelvis positioned nicely. This is an external and this is an internal monitor, okay? We're going to talk about external monitors because usually internal monitor, something's going on that we have to place mom in internal monitors, and we will talk about that. So usually the top, which is the one on the fundus, on the top of that uterus, this one right here usually, okay, is the tokodynamometer, and that is pressure-sensitive device placed on the fundus of the uterus to record muscle movement of the abdomen, and it's held in place by an elastic belt. Okay, this one right here, okay, sometimes it's this way, sometimes it's a little more to the other side. You'll see in the labor room at SCC Lab how we have her on an external monitor as well. This transducer, okay, it's an ultrasound transducer, and it's placed over the fetal back to detect movements of the fetal heart. Now, we'll go back to our picture. Internal monitor is two things that we do with internal monitors. A fetal scalp electrode, that's FSE, a fetal scalp electrode, and I will switch over to the picture, okay? Or an IUPC, intrauterine pressure catheter, okay? Now, the fetal scalp electrode, there's two of them. The fetal scalp electrode over here, okay? It's inserted through the cervix. Mom has to be 2 centimeters dilated, so those are the requirements for internals, okay? Fetal scalp electrode, FSE. It's inserted through the cervix, Okay, patient has to be 2 centimeters dilated with rupture of membranes. It is attached through the epidermis of the presenting part, which is the scalp, not the fontanelle, not the face, and it's going to provide a direct EKG of that baby's heartbeat, of that baby's heart rate. Okay? A direct electrocardiogram of that fetal heart. That is the FSE. Now the IUPC, it's inserted inside the uterus alongside the fetus. There's a little pressure sensor on the tip, and that's going to display the intensity of the contractions. So those are your internal monitors. Everybody will come into the labor room and will start off as an external monitor because policies and procedures and rules and regulations when you come into the hospital to get treatment and you're a labor patient is the only way that we can know fetal well-being is by monitoring the baby with an external monitor. Okay, we see mama, but the only way we can see baby is with the external monitor. Okay? Remember when we talked about non-stress test? It's kind of the same machine that we use. Okay, same thing. This one detects the contractions. The lower one detects the baby's heartbeat. Okay. Now we'll go back to, because we have our follow here in order. When we're doing electronic fetal monitoring, we're looking at variability, okay, rhythmic fluctuations in heart rate. And that's good. There are some babies that move more in utero, and you can notice that in the heart rate, okay? When 10 to 160 is normal, there are some babies that are in the 140s, 150s, and that's okay. They have moderate variability. They have, rhythmic fluctuations, 6 to 25 beats per minute more than their baseline. Okay, so their baseline is, let's say it's we try to figure out what their baseline is, and then we know that they're moving a lot, so they have moderate variability, 6 to 25 beats per minute. It just goes up and down, up and down, up and down, up and down. They're constantly there. Now, if they have marked variability, means that they have more than 25 beats per minute higher than the baseline. So they're very marked. They're moving all the time. Then there's sometimes when the babies have minimal variability. Change in the heart rate between one fetal heartbeat and the next, it's about 2 to 5. I have some pictures to show you. Okay? You get a baseline, but this baby is going. I mean, this baby is like up. It's like 140, 160, 140, 160, 140, 165. Then you've got moderate, okay, minimal, and then of course what you never want to see, which is absent, just a floppy hypotonic baby in utero. Okay, because we talk about baseline fetal heart rate, so I want to show you here. This is a strip, okay? The bottom, like I said, is 0 to 100. That's a 100, okay? This is measuring, This is measuring contractions. The bottom of the strip is always going to be the contractions. The top is always going to be the fetal heart rate. Okay, and just like I have here, the baseline of the fetal heart rate is the average fetal heart rate over 10 minutes. Okay, rounded to the nearest 5 beats per minute. So here it is 145 beats per minute, which is the baseline. So when we're talking about, moderate variability, we're talking about, okay, does this baby go, always up, 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 or maybe just a little 6, 7 beats per minute. Okay, that's the variability. That's the between beat to beats. Okay, and that's what we call that is beat to beat variability. B as in boy, T as in Tom, B as in boy. Beat to beat variability. And you're going to see that in the charts. BTB variability, or sometimes BTBV for variability. Okay? B as in boy, T as in Tom, B as in boy, V as in Victor, beat to beat variability. So let's see if I can show you, okay, a little bit more on here. And then with that being said, we're going to go into electronic fetal monitoring. And this should be, once you go into the lab, this should be a nice, just kind of, we are emphasizing more and more so that you can understand fetal monitoring, okay? So when we go to the lab, hopefully now you've had this lecture, so everybody from here on that goes to the lab will understand electronic fetal monitoring a little bit better, okay? Accelerations is an increase in fetal heart rate, okay? Increase. So you've got baseline of 110 and it's only going higher, increase. Decelerations is a decrease in fetal heart rate. So you've got, and I'm going to give you the definition, and we're going to see the strip in a minute so that you can understand the relationship between contractions and between heart rates. So early begins at the onset of a contraction and returns to baseline by the end of the contraction. This is the most benign, early. If you're going to say which one's the normal of the three, we would say early. It's the most benign because it's fetal head compression, okay, which is a normal that's going to happen. Variable is not, and neither is late. Those are not normal, okay? And if you ask me, I usually say none of them are, because a baby should be able to withstand contractions and never lower their heart rate. Okay, that's why we're always monitoring to make sure that they're not going to lower their heart rate. Variable does occur suddenly, varies in duration and intensity, resolves abruptly. It has a UVW shape when you see their heartbeat. And we will see those, so just give me a minute. We're doing definitions and we're going to looking at the slides here in just a second. Late begins with or after the acme of the contraction, okay, and does not return to baseline until the contraction is over. So this usually is an emergency, okay? A baby's not getting any oxygenation, okay? Baby's really struggling for help. And this one too, because in variable, this is caused by umbilical cord compression. There's an umbilical cord in utero, okay? And it's in there with the amniotic fluid, and sometimes it wraps around their neck, okay? Wraps around their bodies. And variables will let us know that it's an umbilical cord compression. Late is caused by placental insufficiency. Something in the placenta is not giving that baby the oxygen. So we know that if this is happening, baby's going to get into trouble. And here we're going to see some visuals. Fetal heart monitoring interpretation, okay? This is where you get your normal range of 110 to 160 normal, okay? Accelerations are abrupt increase in the heart rate from the baseline and can occur at any time during labor. Okay, accelerations are good. These are reassuring signs of fetal well-being. Okay, remember we said the maternal contractions, they go from 0 to 100. This is the increment. This is the peak, the highest point of the contraction. This is the decrement. Okay, now variables, we said it's caused by umbilical cord compression. So here's an abrupt decrease in heart rate from the baseline. Not good. Okay, not good. Okay, it is common, very common in labor. Okay, variable decels, because we've got the cord and there's not a lot of space, so it happens. But that's why we have to be in the alert. Okay, lates are not good. Okay, fetal distress, yes. Repetitive severe, not good. Okay, there is a gradual decrease in heart rate. Heart rate returns to baseline after the contraction's over. So if the contraction is the tightest, okay, part, and it's like, okay, the baby's like, help, help, let me breathe. Once that uterus relaxes, everything should start normal again, right? Okay, oxygenation, everything normal. It's not in late. So you know something's not right, because even when that uterus is supposed to be nice and relaxed, the baby's heart rate is still low, which is a problem of the placenta. That's why it's an emergency. So we're going to take the 3, okay, again, and I already told you, but now you have it in your slides. So early decel begins at the onset of contraction, returns to normal at the baseline, caused by fetal head compression. What do? We're just doing a sterovaginal exam to see if that baby is descending down, okay? And how we look at it on the strip, again, here's a strip. The bottom is a contraction, 0 to 100. The top is a heart rate and usually goes from 30 to like 240. Okay, and in the hospital, you will see that 110 to 160 is in blue, in turquoise blue, and it's highlighted in turquoise blue. The bells will ring if it's lower, the bells will ring if it's higher. What we're doing here is the earlies, they're mirroring the contractions, okay? So when it's the peak of the contraction, that's when the baby lowers the heart rate. So it's a mirror. They lower the heart rate at the peak of the contraction. Okay. It's usually, early decels caused by fetal head compression. It's benign. We just need to determine with the vaginal exam if the fetus is descending into the pelvis. Now, with variable decels, it's a little different. Okay. With variable decels, it can occur suddenly. It varies in duration and intensity. It can resolve abruptly. And it could vary in relation to the contraction as well. Okay. Caused by umbilical cord compression. Okay. Now, it could be due to, with variable decel, it could be due to the maternal position, like we said before, a nuchal cord, which is a cord wrapped around the baby's head. That's a nuchal, N-U-C-H-A-L, nuchal cord. Short cord could be a knot in the cord. Sometimes we get all these variables happening very often, and when that baby's born, we see a knot. We're like, wow, baby did so well, but it's unbelievable because they had a big knot in the cord. You can have one knot, you can have a double knot. And then a prolapsed cord, which should never happen. Baby should be out first, okay, and always first. And of course, the cord with the placenta. Never the cord first, because what is the cord attached to? The placenta. And if it gets dislodged and displaced and separated, what happens? The baby has no oxygen because that placenta is attached to the endometrium when mama is giving everything to that baby. Okay. We do some nursing interventions. Okay. We are going to change maternal position. Now we're going to, if there's Pitocin in any of them, okay, we're going to DC Pitocin, okay, because Pitocin is going to give us a beautiful strip, but is also going to tell the uterus, okay, contract, contract, contract more because you're not contracting enough, okay. Oxygen, 8 to 10 liters. I'd go with 10 liters, okay, of a non-rebreather face mask. You want to notify the healthcare provider. And in variable decels is really the only time you're going to see an amnio infusion being ordered for variables, okay? Usually an amnio infusion at this point, if we have variables, remember when we talked about in internal monitors, we're going to put, mom is no longer going to be in externals, we're going to do internal monitors. We're going to do an FSC because we want a perfect heartbeat of this baby. Once decels start to happen, we want a perfect heartbeat and we want a perfect pattern of contractions. So we want to do this with an IUPC, intrauterine pressure catheter. So we're going to put the baby with a fetal scalp electrode, and we're going to give mama an IUPC. Okay, and the amnio infusion is normal saline, lactated ringers, infused into the uterus to provide fluid around the umbilical cord and keep it from being compressed. Okay, it's like a bolus, and hopefully that will take the pressure off the cord. Okay, so if it's around the neck, so it stops, choking that baby around the neck, and getting that baby oxygenation. If it's too tight around the baby, the fluid causes some pressure, and of course lets that baby oxygenate. Okay. Then this is examples of variables, and variables usually will give it away because over here it's very abrupt. So if we put mom on her left side, if we change her position, and sometimes you'll labor with mom the entire time changing her position. But she's had variables and we know it's the cord. You put her on her left side and there's pressure off the cord. Oh, baby loves it and does great. And then here we go, another variable again. We put mom on the right side, pressure off the cord. Oh, wonderful again. Okay. So this is a variable decel. The shape of the heart rate is usually a U, a V, or a W. See, a V or a W, okay? Because it's very abrupt and then it goes up very quickly, okay? Sometimes there's a relationship with the contraction, sometimes there isn't. Sometimes there's a relationship with the contraction and sometimes there isn't. And it's still happening, okay? They tend to drop a little bit more, obviously, when the contraction is happening because, of course, everything is tight with the contraction. And then if you have the cord, it's going to be even tighter. So, of course, there's even less oxygenation. So baby's dropping the heart rate. Okay. So in late, which is not good, is the worst one. Okay. Usually there's a gradual decrease in fetal heart rate that begins after the contraction starts. So it begins with or after the acme of the contraction, and it doesn't return to baseline until that contraction is over. And this is the placenta. This is called uteroplacental insufficiency. Utero because the placenta is in the uterus. So uteroplacental insufficiency. Okay. Now, nursing interventions, yes, we are going to change the maternal position. Again, we're going to DC the oxygen. We're going to give mom 10 liters, non-rebreather face mask. We're going to notify the healthcare provider. This mama is going to have internal monitors in, okay, as well. Now, some causes and why. Caused by, okay, uteroplacental insufficiency. Due to, okay, what is this due to? Well, placenta is deteriorating. There could be maternal hypotension happening, and if that's the case, then we give a bolus of fluids. It could be cardiac disease that mom's experiencing, some maternal anemia. It could be, remember the warning sign of pregnancy when mom starts to bleed. Mom can have placenta previa, and late decels will show anything related to the placenta, that baby's getting less oxygenation. Placenta abruptio, because there is that premature separation, and you're going to see late on the monitor. Okay, if there's a premature separation, of course the baby's not getting the oxygen, so absolutely you're going to see late on the monitor. Okay, and of course hypertension, because hypertension is a vasoconstrictor and the blood is not going to flow nicely, in that placenta from mama to the placenta to the umbilical cord to the baby. There's going to be vasoconstriction. So of course, because it's placenta related, because mama's giving everything to baby through that placenta, you're going to see late decels. Okay. And here we are with late decels. Okay. Again, another strip so that you can review them and you can see them. And when I'm telling you, you can understand a little bit better. That's why I gave you a lot of visuals. 0 to 100 again is the contraction pattern, okay? There's that period of reoxygenation to start the contraction again. And there's what's happening. You've got the baseline, okay, 110 to 160. And then, of course, there's that heart rate, okay, dropping. And you know it's a late because after that uterus has relaxed, we see this heart rate still down, okay? And here is another example. It's a real example because you have to, you mark every time you see it. Okay, the RN goes in the room and looks at it and marks it. This is an example of a prolonged decel. Note the duration of the decel lasts more than 2 minutes. Okay, the contraction happened and the baby has not been able to recover before the next contraction. Okay, continues to be down. Tries to recover. Okay, sometimes that happens, tries to recover. Okay, and hopefully when we recover and all will be good in the world, but if they don't recover and they do this, okay, and they do it again and they do it again, mama is going to what we call have a crash C-section and take her in for a C-section. Okay, again, more visuals for you just to help you understand what's going on. Okay, head compression early. Okay, head compression is early. Uteroplacental insufficiency is late. Okay, this is late. Okay, late. Late onset. Okay, you can see the drop. After that uterus is relaxed, baby's still dropping the heart rate. And umbilical cord compression. Okay, there's another example. Okay, head. Okay, head with early, placenta with late, and of course cord with variable. UVW in the fetal heart rate look, how it looks in the fetal heart rate is UVW. Okay? And when you go again to the lab, we will show you again. Okay? So you have us live there. We will show you again. Signs and symptoms of true labor. Okay? Cervical chain, there has to be dilation, there has to be effacement. Okay? Dilation 0 to 10 centimeters. Effacement is in percent, 0 to 100% effaced. Okay, that's the thinning of the cervix. Rupture of membranes, it can be intact or that bag of water can rupture. Okay, intact, ruptured, or bulging. Okay, it could be bulging. And then a lot of times a healthcare provider comes in and instead of doing a spontaneous SROM, spontaneous rupture of membranes, where mom starts leaking at home and she comes in, or all of a sudden she's leaking and we know she's ruptured membranes, or an artificial rupture of membranes, and the healthcare provider has to come in and artificially rupture her membranes. Okay. A bloody show, that's in the absence of a recent vaginal exam. Contractions. Now, true contractions begin in the lower back and radiate to the front of the abdomen. They're regular, they are longer, and they are stronger. Okay, and those are true labor contractions. Okay, begin in the lower back, radiate to the front of the abdomen. They are regular, they are longer, and they are stronger. And then there's lightning, the dropping down of the gravid uterus into the pelvis. Okay, the dropping down of the gravid uterus into the pelvis. That is a lot of times when the moms can put their 5 fingers right on their sternum. Okay, and there's that separation and they're looking like their bellies are lower. That's because lightning has happened. And usually that happens in the 3rd trimester at the end. Then there's that nesting instinct. Okay, remember, these are signs and symptoms of true labor. Labor is close, very close. Burst of energy, this is about 24 hours before going into labor. They're cleaning the house or prepping for the baby. There's also an increase in back discomfort. Sometimes they think that they have the flu and it's just the body getting ready. They've got diarrhea, they've got nausea, they can even vomit. They just don't feel right. It's usually mistaken for the flu, and that's because labor is near. Then we're going to go through the stages of labor. Okay, now the first stage of labor is all about the dilation of the cervix. It has 3 phases. Okay, the first phase is the latent phase, 0 to 3. The second phase is the active phase, 4 to 7. And the third phase is the transitions phase, 8 to 10. And we're going to go through this one by one. First stage of labor, all about dilation. Okay, remember we talked about effacement. Not only does it dilate, but also it thins the cervix. So in the labor room, we have 3 things that we look at to see if that baby is near delivery. We look at centimeters, dilation. We look at the effacement, which is the thinning of that cervix, okay? Not only how big, okay, in centimeters, how wide, but that is thinning, okay, that cervix is thinning. But we also look at station, how low, okay, how that baby is going into that pelvic cavity. And here we are with the stages of labor, okay? We take each of them. So phase 1 is a latent phase. That's 0 to 3 centimeters. We still have that possible emotional state. They're excited. They've got some relief that the labor has started. They're smiling. They're talkative. They want information. They're following instructions. They're eager to answer questions, okay? Which is good because you want to make sure that you give them as much information, okay? That you tell them what to expect, that decreases their anxiety. And then the contractions. They're 10 minutes apart. The duration is 30 to 45 seconds. The intensity is mild to moderate. And then what are the nursing interventions we will do with them during latent, okay? These are the mamas that come to the hospital because they've dilated, because they started to have, the labor pains at home, and we're encouraging them to ambulate. We could do position changes with them, okay, to make them more comfortable. We can do something called effleurage, Effleurage. That's just the gentle stroking down the middle of the abdomen and around the sides. Okay, that's gentle stroking down the abdomen and around the sides. We can still, encourage fluids. They're still walking around. And we always want to make sure, always, that we verify a reassuring fetal heart rate. Always. Okay? 110 to 160. So what happens in the active phase of labor? 4 to 7. Well, of course, now the possible emotional state, we get a little bit more irritable. There's difficulty adjusting to the stronger contractions. There starts to be anxiety. Mama can start to lose her temper. This is when they're going to request pain medication. You will see that in your book it says phase 2 active labor 4 to 7. And that's changing a little bit in the hospitals because epidurals are very safe, and research is showing that we can start them a little earlier with epidurals. So don't be surprised that you will see in the charts in the hospital, in the articles that you read. I know you're not going to clinicals right now, but I know that your clinical instructors will tell you when you are in your clinical days that usually epidurals can get started at 2 and 3 centimeters. Okay, they're relatively safe, and they're going back to old school pretty much when we used to do them at 2 and 3 centimeters. Okay, done by the anesthesiologist, the epidurals. And then, so that's the possible emotional state with active. Okay, you want to make sure that because they're having stronger contractions, that they'll answer questions in short sentences. So make sure you ask them your questions between the contractions. And then there's contractions. Frequency is 2 to 5 minutes apart. Duration is 60 seconds. The intensity is going to be moderate to strong. Now, of course, nursing interventions, we always want to make sure that we can verify a reassuring fetal heart rate between 110 and 160. You can start reviewing with mama information on labor, on breathing, making sure who's going to be in the room with her. I know now through COVID, we're living in different times, and it's only the one person, okay, that mom wants in the room. So it's mom and the one person, okay? Significant other, could be the mom, could be the cousin, could be the partner, the one person with mom. But, when we haven't been doing COVID, we allow family members, and we always tell mom, right when she starts to get into the active labor, who would you like in the room with you? Okay, and then we can nicely tell the rest of the family members to wait in the waiting room. Then we have transition, 8 to 10 centimeters. It's getting closer, so now she's getting more restless. Sometimes she's been doing this for a really long time. First-time moms take a long time to labor. So it's very normal that sometimes they take, there's 10 centimeters they have to get to, and sometimes they take 2 to 3 hours. Okay, sometimes 2 hours between 1 centimeter and the other, Sometimes they take 3 hours between the other one. Sometimes they take an hour and a half. They take usually longer in between the centimeters. So they could be laboring for, 20 some hours, sometimes even 30 hours, the first time moms, because the cervix hasn't dilated, hasn't done it. They're doing it for the first time. Now, multips that moms have already delivered, of course, the cervix has already dilated once and come back again where it has closed. And then with hormones, it gets soft again. And mama's, does her 10 centimeters again. Then they tend to labor a little bit quicker and not spend so many hours in between centimeters laboring. So their labors tend to be quicker. First time moms usually take a little bit longer. Possible emotional state, yes, again, they're restless, they want to quit. Sometimes they're irritable, they're requesting a C-section, they just want to get over with it. They want their baby, they feel they can't do it anymore. And you're their cheerleaders. You're going to be there with them, you're going to tell them you're going to be there with them, and we're going to do this together. Okay, contractions, now they're more frequent, so they're 1.5 to 3 minutes apart. They last a little bit longer, 45 to 60 seconds. They're stronger. Nursing interventions. You want to assist mom with relaxation, with some breathing techniques. Of course, if we have to tweak the epidural, we can give her a little bit more if need be. Always make sure, number one, big star is you're always wanting to make sure, plus they're on the monitor in the room, so that's you're always looking at that, because that's your lifeline to the baby, is that we're verifying a reassuring fetal heart rate. And we're giving instructions, obviously, in short sentences. We're praising, we're encouraging mom, and please don't leave her alone. Sometimes if that family member will come out to the waiting area where the nurse's station is at and says, she doesn't want me to talk to her. She's told me to just leave. And we'll say to him or her, please, just go in a little corner of the room and just wait there. She's working through her contractions, and that way you can be her eyes and her ears. If she needs us, then we'll go ahead and we'll go in. So sometimes that transition is probably not the time to go down and get some coffee. Also with transition, a lot of times you will notice that mom is getting closer to delivery because she'll start to get nauseous and she'll throw up. Even if it's just clear, she'll tell you that she's nauseous. And it's because she's in that transition phase of 8 to 10 centimeters. That usually gives her away that it's, the time is getting near. So the first stage of labor is all about dilation with the 3 phases. Now we're on the second stage of labor, and that's the complete dilation of the cervix and the delivery of this baby. Okay. There's crowning, which is the outward bulging and thinning of the perineum. Okay, that's the opening of the vagina that occurs as the fetal presenting part, 97 to 98%, is a fetal head. So that is the opening of the vagina that occurs as the fetal presenting part presses downward onto the perineum and it becomes visible prior to delivery. Okay, and again, 97 to 98% of the time is a fetal head. Okay. Another thing that I want to talk about when we're talking about the second stage, when there's complete dilation of the cervix and the delivery of the fetus, is we want to make sure that before we have mom in the second stage, we have her pushing. She can't push until she gets to the second stage because she can't push until she's completely 10 centimeters dilated. Okay? We have to make sure that we've emptied her bladder. So if she feels like she has to go to the bathroom and she can't, we have to make sure sometimes we'll just do a quick straight cath, okay? Because if she is unable to void or she has a full bladder, her bladder will be distended and then it won't allow for the descent of that fetal head. So it makes that process a little bit more smoother, okay? And then we have cardinal movements, okay? And these are the adaptations that the fetus undertakes to maneuver through the pelvis during labor and birth. You don't need to memorize these. You can read it in your book as well. It's page 336. It's amazing to see how much the baby does in utero, how much this body gets ready with all these hormones to be able to help this baby. And then the baby is maneuvering itself in utero. And then, of course, we do the little help. Once there's a crowning, once there's a pushing, once we see the head, we're going to help, right, about have pictures, live pictures for you. Right here, we're going to start helping over here with the pushes, releasing the shoulders, anterior, posterior shoulders for that baby to come out. I've got pictures for you. Okay, so review the cardinal movements as well. Just know that they're the adaptations that the fetus undertakes to maneuver through the pelvis during labor and birth. And then go over them as you read your chapter. Okay, it's on page 336 of your Lippincott book. We can go through the delivery so you can see what I was talking about. When there's crowning and you see the head, the healthcare provider that's going to deliver applies gentle pressure to the infant's head. Then we have to examine the neck for looped umbilical cord. That's for the nuchal cord. Okay, usually put 2 fingers to make sure it's loose enough that we can loosen it up over the head. Okay, if not, we have to cut and clamp. Support the infant's head as it rotates for shoulder presentation. Okay, now we have to guide the shoulders to deliver the anterior shoulders and then maneuvering up to deliver the posterior shoulders. And there you go. Okay. Now, stages of labor. Okay. Again, 3rd stage. So we're still in the stages of labor. This is our 3rd stage of labor. And this is actually the birth of the newborn to the delivery of the placenta. Okay. So the 1st stage is all about dilation. The 2nd stage is when mama can fully dilate it. Now she can push. And that 3rd stage is that birth of that baby and that delivery of that placenta. Okay. Of course, we're going to monitor blood pressure, pulse, respiratory rate every 5 minutes. And then we've got the 4th stage of labor. Okay. And this is a delivery of the placenta. And this is 1 to 4 hours after birth. Okay. Monitor vital signs. Now, this is after birth for a vaginal delivery. And if it's a C-section, you're going to do respiratory rate. When we talk about vital signs, you're going to do respiratory rate every hour for 24 hours. Okay. When we do vital signs, when mom's delivered vaginally, we're going to do every 15 minutes for an hour. Okay. We're going to do fundus check. Okay. Want to make sure the uterus is contracting to prevent that blood loss. Okay. The fundus check, the placement. I've got a picture. Okay, of a fundus check. You always want to make sure you put, you support, see her hand right over here. Okay, she's got support with the bottom of the fundus and then support with the top of the fundus, and making sure that you can do a placement. So how high, okay, how firm. We want to make sure that it's at the level of the umbilicus. Okay, so another picture to show you with the fundus check. Okay, remember this uterus had a baby. Once this uterus no longer has a baby, we need to check. Okay, there is a process called involution, and we're going to talk about that in postpartum involution, and that's the process, okay, of this uterus going back down to pre-pregnancy size, like right here, okay, when mama was not pregnant. And what we're looking is, see right here, what we're looking as, this is the process of involution, okay? We're assessing the uterus for involution, and this is good. That's why mom has to continue to have those contractions. This is why breastfeeding is wonderful, because it's a natural release of oxytocin, which is a natural form of Pitocin. And that helps for that uterus to involute, to come back, okay, to pre-pregnancy size, so that it's in the pelvic cavity. And if we're not pregnant, no one can look at our uterus. It's nice. It'll go, let me see if I can get my cursor. It'll go right in here, okay, and we don't assess the uterus. Okay, we can't feel it. Okay, so back to our assessment when we are assessing. Okay, so we put one hand always to support, okay, the bottom, the symphysis pubis, the bottom, and then the top. And what we're doing is our umbilicus is the guide, and it's 1 to 2 finger breaths below the umbilicus for every postpartum day. 1 to 2 finger breaths below the umbilicus for every postpartum day. Okay, so we're looking at 3 things: the level of the umbilicus, okay, making sure that it's 1 to 2 finger breaths below the umbilicus for every postpartum day, that it's firm, and that it's midline. And that's how we do our fundus check. Okay, our lochia checks, again, we have our pads, okay? Red, it's going to be, it's cleaning, that uterus is cleaning out, okay? So we're going red is rubra, R-U-B-R-A, and that's usually about the first 48 hours. It goes to pink, which is serosa, and that's usually can go from like 3 to 10 days, okay? And then it's going to go to alba, and it could last from like 3 to 6 weeks. And alba is white and yellow. So it can go rubra, R-U-B-R-A. It's red. It can go from rubra, bright red in that first 48 hours, to pink. Okay, that lochia changes, that discharge, that cleaning out of that uterus. Everything is sloughing off. Okay, it's 3 to about 10 days, and then it goes pink, and then it starts going from pink to white to yellow. And that's alba, A-L-B-A. And we will talk about this again in postpartum. But this is we have to remember that this 4th stage is the immediate 1 to 4 hours after birth. Immediately 1 to 4 hours after birth. Okay? We can do a perineum. So let's go back to our list. We just had some visuals for you. The perineum, okay? We check the rectal area for hemorrhoids because mom has been pushing if she's vaginal delivery. If she had a C-section, there's a Foley in place, and it'll be DC'd in about 12 hours. There's the incision. Okay, we need to make sure the incision is intact. Sometimes for the meds, there's something called a SMAC kit, self-administered medication kit. And usually mom will have it at the bedside. And all it has is ibuprofen, okay, acetaminophen, Colace, and a dermoplast. Okay, it's a spray to the perineum. It's PRN. So ibuprofen, it's about 200 milligram. You can do 3 tabs, PO, every 6 to 8 hours, PRN for mild pain. Okay, and the pain that we're talking about, that's called after pains. That's like menstrual cycle pains, okay? That is because the uterus is still contracting because it has to go down to pre-pregnancy state. Okay, so those pains, those contractions in the uterus is going to be called after pains. Okay, there's acetaminophen that mom can also take, 500 milligram tabs, 2 tabs, PO, every 4 hours, and that's again PRN. You try to keep her away from taking the narcotics because she's going to be going home, okay, soon, okay. Now, Colace is 100 milligrams, 2 tabs, PO, PRN, okay? And that's for constipation. Dermoplast, okay, it's a spray to the perineum, and that's going to be PRN. And that's going to help mom, especially those mom that have labored for a really long time. Okay? Then, of course, eyes and nose are very important. Fluid, regular diet is tolerated. Okay, if she's a C-section, and we were going to talk about that in postpartum, we have to listen to her bowels, make sure that those bowels have come back before we can feed her. And anything that you can think of that's emotional status, breastfeeding, anything that you can think of that's emotional, all goes in the 4th stage of labor. And a list there of non-pharmacological method of pain relief. So we have, again, we have effleurage that we talked about, the gentle stroking down middle of abdomen and around the sides. We have a focal point, and that's for concentration. We have Lamaze breathing techniques, and you can look those up at www.lamaze.org. Their mission for Lamaze, their mission is to promote and support and protect natural, safe, and healthy birth through education and advocacy. It's wonderful. Great techniques for mom. And if she goes to birthing classes, she will be taught the Lamaze breathing techniques as well. And comfort measures for her for labor, position changes. We can decrease the weight of that fetus from area of most intense pain. So we could go left, right. There's a lot of pictures in your book that suggest those comfort suggestions for labor. Cool or warm washcloth, therapeutic touch, words of encouragement, lip balm, soft music. That's non-pharmacological methods of pain relief. Then we have analgesics in labor, okay? And analgesics are Demerol, Stadol, Nubain. Now these are still exist. It's in your book. You've got it there. You can look it up in your drug book. And also, please write down fentanyl and Toradol because you will see these now in the hospitals more and more. Fentanyl, Fentanyl, and Toradol, Toradol. Okay, so look these up. Okay, we've cheated, so I've got the Demerol and the Stadol and the Nubain for you, and those are given IV or IM. But fentanyl and Toradol have pretty much taken over as well. But not that we don't give Demerol and Stadol and Nubain, but fentanyl and Toradol have pretty much taken over. Okay. Anesthesia in labor, epidurals. Epidurals are famous. They're very safe. Needle is placed in the epidural space, L4, L5. There's a picture right here, so I will go to this picture. Okay. The epidural space. Now, before the epidural, we have to prep mom, and we're going to give her a bolus of 500 to 1,000 cc's of lactated ringers. Okay, that is for possible hypotension. It is a reaction the body gets when there's an epidural. The blood pressure tends to drop. So for possible hypotension, we're going to give a 500 cc's to 1,000 cc's of lactated ringer bolus. Okay, and your book has also a good picture of a mom receiving an epidural. She is not going to lay down. She's going to sit on the edge of the bed. We're going to put a seat under her feet. We're going to curb her spine, and we're going to insert, and that is the anesthesiologist, will insert the needle in between contractions. Take a deep breath. The nurse is there. We'll put a pillow in front of her. She'll hug her pillow. She's curving and she's hugging her pillow. We're going to put the epidural catheter in between her contractions as she takes a deep breath. Okay? It is given usually in the first stage with phase 2 in active labor, like we said, 4 to 7 centimeters, but don't be surprised that you will see it given a bit earlier. 2, 2.5, 3 centimeters. It's safe for mom. The rationale for not giving it too late in delivery or too early is because if you give it too early and she labors for 25 hours, you're going to have to tweak the med. Okay, and that's okay. You can tweak it. If you give it too late, it's too close to delivery, and we want to make sure that baby will not get respiratory, depression from the epidural. Okay, so that's what we worry about. So we want to make sure we give it in a nice balance of between 4 and 7 centimeters with the anesthesia. Okay, so that it works. We can tweak her anesthesia, and then she has nice relief. So when she's gonna, labor, she's pain-free, okay, and she's not suffering all the way through. Great advantage. It has excellent pain relief. We can redose the medication. There's no neonatal respiratory depression that happens when you give it. And it might even provide a few hours of postpartum pain relief. Now, a little disadvantage, yes, you need the anesthesiologist, okay? It does cause numbness, and there's that picture with the blue. It does cause numbness to the lower extremities, limiting the mobility. Sometimes it gives you little or no urge to push. If it's done correctly, you still feel a little bit of that, you know, a little pressure, so that every time there's a contraction and everybody, in the room, the doctor and the healthcare provider, the nurse, your significant other, your partner will say, okay, push. You still feel that urge. At least it's a little urge to push. Okay. And then some nursing interventions. Of course, we're going to monitor urinary output. So we have that catheter, that urinary catheter. We're going to monitor that blood pressure for hypotension. And we're going to avoid that supine position. So we're going to lay her on her sides. Okay. So what we are monitoring her is we give her that bolus. We get some baseline vitals. We get her lab work. We make sure that her bladder is empty. And we do close monitoring, okay, with mom. Then there's another one called, we're talking about anesthesia in labor, is pudendal block. And pudendal block, I have a picture as well. It's a local anesthetic agent injected into the lateral vaginal walls near the ischial spine to anesthetize a pudendal nerve. And when is this given? This is given during the second stage of labor. Okay, remember, second stage is the stage where now mom can actually push because she has reached her 10 centimeters. So this is in preparing for her to, to do a little cut and to prepare an episiotomy. We will talk about episiotomy when we talk about high risk. But this is an example of what the healthcare provider is doing. Okay, local anesthetic agent that's injected into the lateral vaginal walls near the ischial spine, and you can see the ischial spine right here. Okay, and you can see the pudendal nerve. Okay. Advantage is excellent anesthesia of the perineum. Okay, provides a few hours of postpartum relief. Disadvantage is that it's injected along the presenting part, creating an increase in vaginal pressure. Sometimes it eliminates the urge to push if they've put a little too much. And nursing intervention, you have to monitor the patient's safety, as it has decreased sensation in the lower extremities. So it's going to obviously affect mobility. And then last but not least, we can't go through labor if we don't talk about Pitocin, okay? Pitocin can be given IV, Pitocin can be given IM. There's written orders in the hospital for Pitocin, okay? There's, management of the patient receiving Pitocin. You've got your guidelines on there, and we're just going to go through a couple of those goals and outcomes of Pitocin, since it's such a wonderful med, but it's a lethal med, which we have to really keep an eyeball on mom. Okay, you've got your indications there: induce or augment labor. Okay, and of course it's through an IV. There are some contraindications that we have to worry about. CPD, cephalopelvic disproportion. So if the pelvic bones, okay, there's something with the pelvic structure. Remember, the pelvis is very important in a mom either having a vaginal delivery or C-section. The baby can't go through, cephalo meaning head, pelvic being the pelvic bone, and disproportion meaning the baby can't descend down into the pelvic cavity. Remember the stations. If the baby's still floating up there, we're not going to give Pitocin because the baby is not going to go down. It's not going to go into the pelvic cavity. We're going to go for a C-section. A malpresentation, we're not doing that to breech babies because those are C-section babies. Anytime there's fetal distress, absolutely not. We're going to deliver. Preterm babies, no. We want them in utero to be full term. And then yes, Pitocin, because we're telling the uterus, okay, contract, 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 there could cause fetal hypoxia, abruptio placenta, that premature separation of the placenta, history of very rapid labor, and then of course uterine rupture. Okay, so some goals and outcomes of this wonderful, famous medication. Okay, what we want to do with Pitocin is we want to cause effective contractions that will occur without fetal or maternal complications. Okay, a couple of pointers with Pitocin. The healthcare provider must be available for contact during Pitocin infusion. We always have what we call house healthcare providers. We always have the house there, 24 hours at the reach of an arm. Okay, they're always going to be there. Okay, because we run deliveries 24/7. Administration and intervention of Pitocin is performed by an RN, L&D qualified. Okay, and before we run Pitocin, we have to obtain a baseline fetal monitor strip for 20 minutes. Okay, we're also going to perform a sterovaginal exam prior to starting Pitocin so that we know what centimeter she's in before we start Pitocin. Okay, so healthcare provider must be available for contact during Pitocin infusion. Administration interventions are performed by the RN and L&D nurse that's qualified. We've got to obtain a baseline fetal monitor strip for 20 minutes. And we're going to perform a sterovaginal exam prior to starting Pitocin. We're going to initiate IV Pitocin. Okay, and how we initiate is 0.5 to 2 milliunits a minute. We're going to increase by 1 to 2 milliunits a minute every 20 to 30 minutes. And that's how we're going to establish a contraction pattern. Then we're going to evaluate fetal heart rate pattern every 15 minutes. So that RN, that labor room nurse, is going in that room very often when patients are in Pitocin. Okay? So they evaluate that fetal heart rate pattern every 15 minutes. Okay? And then every time the dose goes up, every time the dose goes down, okay? Anytime there's a dose that's either unchanged or goes up and down, every 30 minutes, you're going in there and just like the strip that you saw before that had the initials and the time, we're going to do that and we're going to see and we're going to check and we're always checking for D cells. We're always checking that fetal heart rate pattern, okay, that heart rate in comparison to the contractions, okay? We're going to, we monitor, we record vital signs each time the Pitocin goes up, each time the Pitocin goes down, every 30 minutes. Okay, so fetal heart rate pattern is every 15 minutes. We're constantly making sure there's no decels. Accelerations is what we want. Baby's moving in utero, so we want beat to beat variability. And then, of course, we're going to monitor, record vital signs each time that Pitocin is up or down, which is at least every 30 minutes. Okay, and of course, we've had our baby, right? Baby girl. This concludes our intrapartum lecture. And the next lecture that I will send to all of you is postpartum. Thank you so much for listening to your intrapartum lecture.